Good evening. My name is Keith Rose, and I'm your moderator for Advances in 911 Emergency Services. This is our first live event here at the Midland Cultural Center in almost 2 years, and we're glad to be back. I want to extend a special warm welcome to our live audience sitting in front of me. You are a small but mighty crowd, and it's so encouraging to see your twinkling eyes, even though I can't see your smiles because they're hidden by masks. Collectively, we thank you for observing our infection protocols. We're also very pleased if you're joining us either live on Rogers TV or on your electronic device, whatever that may be, by streaming live from Rogers or on Facebook Live. So great to see this wide audience, some of you here and others out in cyberspace. In future, we will deliver all of our health programs live at these 3 locations on the night of the event. So stay tuned for more information about that. So tonight, let me introduce our 3 speakers sitting in front of you here. And I'm going to go in order of the way they're sitting beside me here. JC is to my immediate left. JC Gilbert is a paramedic and the Deputy Chief of Simcoe County Paramedic Services.
Good evening. Thank you.
Lisa Longworth, sitting in the middle there, is from the Ontario Provincial Police. She's the Provincial Mental Health Lead and Program Analyst with the Ministry of the Solicitor General. Thanks, Lisa, for traveling all the way from Woodstock today to be with us tonight. Thank you. Marty McNamara, on my far left, is started his career as a paramedic, so you can see why he's here. And for the last 20 years, he's been an ER doc at Georgian Bay General. Marty has always been a strong supporter of the paramedic program. He's now the co-medical director of the community program here in Simcoe County. Even though we don't have fire representative, I have been speaking to Paul Ryan, the fire chief for Midland and Penetang, and I thank him for producing some messages for us around fire safety, and I'll get back to that a little later on in the program. More detailed biographies for our speakers, if you've had a chance, they're in the program. You'll see them. That's online if you don't have it with you tonight. Thanks. I want to start with some collective thank yous. First of all, to the Our Health Advisory Committee, in particular Larry Arnold, wherever he is, down there. Okay, Larry, thanks for putting this program together, for making the lion's share of the work, and it's all come down to tonight. About 4 months of planning? Good. I'd also like to thank our 7 local sponsors, and I'll say something more a little later on. And specifically, I want to say a great big thank you to our volunteers here at the Midland Cultural Center, our staff at the Midland Cultural Center, and to the Rogers TV, who've got many people operating the cameras tonight and other people working in the background to make sure that it looks right and it sounds right, and to our sound technician too, Glenn. So thanks to all of you. During the first hour of the program, we'll hear from our 3 speakers. And then there'll be an opportunity during the second part of the program for more specific discussion with audience questions. So please continue to forward those questions during the show to mcc_ourhealth@outlook.com. So we'll try our best to respond to the questions we receive. So at this point, I want to open up and begin our discussion with our 3 speakers. And JC, I'm going to ask you to start, but I want all of you to pipe in on this one. So if one of our audience, Hudson down there, if you make a call to 911, how does that call initiate that there's either a fire truck you want, or you want a police officer, or you want an ambulance? And sometimes you want all 3. So how does that happen, that you end up with these people at your door in as short as time as possible? JC, do you want to walk us through some of that?
Sure. So the 911 response is pretty complex. 911 is its own operations center. It's a call taken by 911 operators. In the county of Simcoe, it's handled through two different agencies, whether it's an OPP agency or a fire agency that handles that call, just based on some geography to split up the work. And from that initial 911 call, you'll always hear police, fire, ambulance. That call taker may take a little bit more information. You'll be then transferred to one of the comm centers for either the local police service in the county of Simcoe. You're looking at OPP, Barrie, or South Simcoe for any one of those circumstances. From a paramedic services perspective, we cover the entire county, including the two separated cities of Barrie and Orillia. And then locally, there's 19 different fire services within the county of Simcoe. So once that decision is made, it's sent to our comm center. So for argument's sake, we'll say you need an ambulance. It comes to our communication center, which operates out of the city of Barrie. And they'll take more call information and immediately dispatch the ambulance. Should there be a requirement for more assistance on the call, a fire element or a safety element, they'll share that call with those respective comm centers, and vice versa. When the call initially goes to the fire service, being a fire emergency, if generally there's a need for ambulance on those calls, and there's security issues. So we'll tier all three agencies to those. So it's pretty complex. There's a lot of interoperability between the services.
How long does it take between your call, Hudson, and actually somebody's dispatched with one of those vehicles?
That's a tough one. In some cases, it can be a matter of seconds. In others, it can take a minute or two to elicit the information, the caller on the end of the phone, what level of emergency it is, how concise, and even the awareness of where they are. Knowing where to send the resources, usually 9/10 of the battle. So getting that information can sometimes take a minute or so, a couple of minutes to process, and then maybe another minute or two processing at the local communication center.
Marty, you're in the emerge. Do you just listen for the sirens, or have you got some warning that something's coming? What happens?
No, from our end, we interact with all three of the emergency services, and what we see coming in, while one may be the primary agency, there's an overlap in their duties. So, for instance, it's common for paramedics dealing with mental health patients to have the police involved to assist them. It's common for, if an ambulance isn't immediately available, it's common for fire department to be dispatched with an automated electronic defibrillator. And so we may see one service or all of the service arrive to our emerge. Typically what we like to see happen, and most of the time the paramedics are great at this, is they'll give us a pre-alert. So we have a dedicated line in emerge that's only available to the paramedic. It's like a hotline. And when that line rings, we have our triage nurse that picks it up fairly quickly, or occasionally a physician walking by will pick it up. But that information allows us to prep the room. So
in a severe emergency,
there will be a bed available. We've had cases where we've had to move patients to hallways, or move patients to the OR room, or move patients to recovery. Anything needs to be done for critically ill patients will be done. And that's our reason for being there, is to deal with critically ill patients. We don't do as well with chronic care, but we do really well with emergencies. And so with that pre-alert, typically 3 to 5 minutes, we can have the nursing staff and the physicians assigned. We have our respiratory therapists there. Depending on occasion, we may even have a surgeon in the room, depending on what the call is. So whatever information the paramedics can give us helps us to set that up.
Great. Lisa, anything to add from an OPP perspective?
I think the additional layer that the Ontario Provincial Police has recently added is a crisis call Diversion Program, and that was launched initially in our West region, and it's expanded to all of our communication centers. So the OPP Communication Center is in Orillia, but services the entire central region. And we have embarked on a program that partners us with the Canadian Mental Health Association, Simcoe County, and we now have a crisis worker, a mental health professional who's on every shift of our in our comm center. So they're working at a station alongside the call takers or communication operators, and they have the ability to be conferenced into the call should it be identified that it would be appropriate to do so, and they'll be conferenced in to offer some additional support.
So it's not just one person sitting there making all these directions. There is a consultation process going on quickly.
Yes,
from the
absolutely. Yeah, absolutely.
Okay, thanks. Okay, JC, the floor is yours to start talking about your favorite topic for discussion, which is the Community Paramedic Program and whatever other advances in 911 services on behalf of EMS that you want to talk about.
All right,
And I'm inviting the other participants to kind of ask the questions too as we go along.
Sure. Our community paramedicine program is really a new program to the area. Community paramedicine in itself is a newer way of dealing and working with the community on chronic disease and chronic illness management. Our mandate, our objective is actually to not have to take people to the hospital. In a lot of circumstances, we tend to be the answer to system frustration, challenges with seeing primary care, challenges with really wanting to stay at home, long wait times in emergencies. The system frustration then leads to an exacerbation, so a really heightened issue with a chronic illness, which will lead to a 911 call. The community paramedicine program in our area is really focused on helping people age and deal with their chronic illness at home safely, and to avoid those unnecessary 911 calls, to not get to the point of exacerbation, to be able to understand and learn and cope and mature through the illness process.
So take us a bit through why the ministry was so supportive of this kind of work that you're doing.
Yeah, it's been a bit of a grind, to be honest. We've been in a little box for a long time from a paramedic's perspective, a paramedic services perspective. It's always been a 911 emergency, collect the patient. You must transport to emergency room. It's our only destination. It's a very challenging situation when you know that there's, in some cases, an alternative that could fix that. The ministry's gotten on board with us in a couple of years. 2 ministries have. The Ministry of Long-Term Care has seen the benefit. A lot of wait times for long-term care placement, seen the benefit of helping people, again, cope with their ailment at home rather than waiting till it's a crisis point and they need to go into long-term care or they're taking up long-term hospital beds, which Marty can probably attest to. There's a lot of people that are coming in through the emerge that really just need support, but they get trapped in the hospital.
There are many patients that we'll see in emerge that had a little care 2 to 3 days earlier, might have avoided the visit. So, for instance, our patients with complex chronic diseases, often there are warning signs 2 and 3 days before the actual critical presentation. The paramedics, I think, are eminently skilled to recognize 2 things. One is now that they've progressed to understand chronic diseases, they still have that emergency training. And so when I'm talking to them on the phone, if they tell me, oh, this patient has a history of congestive heart failure, they can express the situation much more clearly, I think, and succinctly, and we can come up with a plan that will stop that patient from progressing to a heart attack or to heart failure days down the road, keeping them comfortable in their home, keeping them safe.
My understanding, too, was that there was a challenge with patients that presented very frequently at emergency departments with those chronic diseases, congestive heart failure, COPD, and diabetes, that they were a frequent person that came to the emerge, and the question was, do they really need to come to emerge? And you're coming very frequently, and you've made great inroads on that group of patients, my understanding. So
absolutely, and that really was the catalyst of the programming, is understanding our frequent users as well. Generally, in that demographic, the people that present a lot at the emerge access through us. We're a closed resource. We only have so many resources in any run of a day. And when you start to see the repetitive nature, repetitive use, you look for a way to intervene that. So we started with a small cohort of maybe 99, 100 people that we realized were seeing, calling us. The measurement we used was at least 5 times in a 6-month period. And we started to see those people in a small kind of a trial program. We started in more rural communities in Simcoe County. We were able to kind of overlap it within our 911 response, where those communities we were struggling with the geography being huge green space in the county of Simcoe. We're proud of it, but it does present a problem sometimes. We're placing single paramedic responders in those communities, knowing that the emergency call volume is low. And we'd have the capacity in between 911 calls to see people with chronic illness that sign into our program and help manage that illness for them. That was a very successful program, and we lobbied quite strong with the government and with the ministries to say our community paramedicine programs, and we're not the only ones, don't get me wrong, across the province, across the country, around the world, community paramedicine is quite prevalent at various degrees of expansion and growth in different areas of the world. In Ontario here, it's something that's really on the bleeding edge of what we're doing. So across the province, we're seeing some significant growth in programming as well. But here, we advocated quite strongly. And when you start having those conversations at bigger levels and at larger tables, the Ministry of Long-Term Care recognized that we were an asset to that environment as well, that the long-term care wait list, especially in the county of Simcoe, is quite long. And the time span of getting on that list, and the only way to really access long-term care is through your primary care physician. It's not something you can just really put your hand up for unless you're going to go private, and that's a whole different kettle of fish. So helping people manage their time on that wait list is also really important. We hope to see people not need to transition into long-term care as our program grows, to be able to stay at home and age comfortably at home and not have to be uprooted. So and managing those illnesses.
What kind of training do your paramedics have, or you? What time to get to be a paramedic, and then do you need extra training to be part of the community program?
For sure, we the training again has been quite robust over the years. It's always grown and looked to morph and expand with the need of the community. We're very evidence-based in what we do. So as a paramedic at entry level, it's a 2-year program at the community college level. Then there's the next iteration of an advanced care paramedic, which is another year and a half of schooling. The community paramedic is kind of like a snap-on tool. We're fortunate to have our own internal program here. It's not something that's prevalent in the broader educational system as far as universities and colleges go. We've hired some specialists and created our own curriculum. And we do about 3-4 months more training, really intensely focused on chronic disease management for those paramedics to get that advanced knowledge, to be able to speak at the same level with the physicians and with the NPs and the primary practitioners for these folks, to make sure that we're communicating the issues at a very concise level.
If one of the members of our audience has a family member or a friend that they think, having heard what you've said, this patient could benefit from being on the community paramedic program. How does that happen?
It's a referral process. There's so many different ways to get into the program. You can speak with your primary care physician, who can then dig through and find the way to get there. We're presenting on a regular basis to anybody that'll listen, in all honesty, trying to get it out there. We can get access to us on our website. I know that can be a challenge for some of the people that are looking towards us, but if you hear about it, you can ask a family member, ask a friend. Get to our website at simcoe.ca, go to the Paramedic Services tab under Community Paramedicine. There's a referral form in there. It's very little bit of information, and if that's not possible, call the County of Simcoe, look for somebody in Paramedic Services, and we'll get you to the right space.
I think in one of our references tonight, we referenced the Community Paramedic Program, and you can just click on that, and that's kind of interactive. You can
Perfect.
to the referral site. Okay, that's great.
I think it's so important. You touched on the green space, and in my experience working in different communities, the community paramedicine program is just invaluable, and especially in rural communities. When we kind of take on the attitude of, I don't want to drive all the way into the emergency department, and then we'll leave things too long, and it just seems to be invaluable in that regard.
It can be invaluable, and I think it comes down to changing the way we do things. Historically, when I was a kid, you'd have to drag people in, with an arm hanging off to think to maybe go to the emergency room. Nowadays, it's a little bit more accessible, but we have to shift the balance and help people understand that if you're sick and you need it, that's the place to be. Our program is going to help mitigate the volume challenges with that. Understanding that there's limitations. There may be times when we say, wow, we really do have to go to the hospital this time.
What other things recently are the paramedics doing? Because I got to say, I've been impressed that this is a group of people that's looking for more work to do, and they're a highly trained group. They're ambitious and they want to do something. What better setup than telling somebody they have to do it? These are people that want to do it from your group. Right. So I've heard paramedics mentioned in drug overdoses and vaccination clinics. Just walk us through some of those areas.
The pandemic's opened a lot of doors for us. Again, we've been really in a bit of a box over the years. When the pandemic strikes, the resourcing becomes the biggest challenge, right? The system becomes overwhelmed, and who better to look at to help out? From early days in the pandemic, we get involved really quickly in community testing. There's people that either can't get to a testing facility, don't want to go to a testing facility, those sorts of things. We're starting to do, we're working in the clinics alongside the physicians and practitioners in those areas to get the testing done, as well as the vaccination clinics. Provincially, we were able to get a directive written that paramedics can administer vaccinations. We were working in all the clinics across Simcoe County, up to, I think there were 7 running at any one point in time. But then we really got involved with some of the hospital groups and public health through a really strong partnership there for the homebound vaccinations. There's people that just can't get out of their homes, or they live so rural that it would be more of a challenge to get to a clinic to get them vaccinated. So we started actually taking the vaccine mobile, something that wasn't in the initial design of the vaccine, pretty unstable from a timing perspective. But again, we're used to working under time constraint. So to get that vaccine in our hands and move it to people's homes has been a really big leap for us. We've also done a lot of work in the vulnerable population that was identified again at the outset of the populations, at the outset of the pandemic, as a very at-risk population. So knowing that the vulnerable folks that are on the streets that are homeless, setting up opportunity for wellness clinics for those folks across the county, again, in every community that invited us, working alongside the primary care practitioners, able to set up clinics for those folks just to have their day-to-day medical needs assessed, but also having a referral point for those mental health supports. It's been a really key part of that program, is working alongside with CMHA and public health and making sure that people get what they need through that system. They're often unattached. They don't necessarily have a family physician when they don't know where they're going to sleep the next day, let alone how to get a doctor's appointment. So working closely in those agencies, we've been able to make some pretty big inroads.
We did a program on addiction here probably 3-4 years ago. Time flies. But at that point, they were just initiating easy access to naloxone. Prior to that, you had to be certified, you had to do a lot of things. So how has that been integrated into the paramedics' activities?
Yeah, I mean, the prevalence of overdose in the community is quite high. It's on the news all the time. It's something that's really been a bit of a wave across the country. Every time you see something happening on that West Coast, when in this respect, it tends to slide its way across the country. So we've seen it coming, and we're able to plan a little bit forward. I know that a lot of physician groups and mental health groups did a lot of work trying to get in front of it before it came here. But from a paramedic perspective, our directive on naloxone use is expanded. It isn't the answer. It isn't the key. We don't use it as much as one might think, really, because naloxone is a medication that the half-life of the medication, so the wear-off speed of that medication, is twice as fast as the longevity of the drug that's causing the problem. So the antidote will actually wear off quicker than the drug that's causing the problem. So we tend to use other skills to assist people with a little bit of assistance in breathing, just even some stimulus in one way or another to wake them up a little bit, rather than going straight to the naloxone. From the public perspective, an overdose response immediately to that naloxone, because there's we got a lot of education, knowledge, and capacity within us. So we're working to expand the availability of naloxone kits. When we go on these calls, recognizing the prevalence of opioid use in the public and being able to work, again, with partnerships in public health and leave naloxone kits for people in the event that something was to happen again in the future. We want to make sure those people get to the hospital and get the treatment they need, but having the availability of the kits in not such a lockdown manner is really helping people a lot.
So along with that, hospitals in Ontario, as well as a lot of medical centers, will have naloxone kits to give out to people we know who are at risk. Right. And I think that's paid some dividends. I've seen a number of people come into Emerge who have been not only helped by the paramedics with artificial respirations with bag valve mask breathing, but also with doses of Narcan to keep them alive until we can assist them in a more safe setting. Yeah.
So let's digress just a little bit. Naloxone is an emergency life-saving drug. You also manage the Defibrillator Program, which is an emergency life-saving instrument to give somebody a shock for their heart's not beating right. So tell us a little bit about where the EMS is involved in that too.
Okay,
JC?
sure. The public access defibrillator program in the county is really robust. We've got a little over 700 public access defibrillators across the county. You'll see them in arenas, in community centers, schools, a lot of different agencies. There are some private companies that are starting to get in the game as well with safe stations in communities. It's nice to see. From our perspective, we'd love to see a defibrillator in anybody's hands that can use it. It's a fully automatic tool. It's self-instructed, so there's a voice that pops out of it that tells you how to use it. So we really want people to not be afraid to use them. You don't need to be certified to use that. It's a pretty straightforward tool. And we see low usage. However, when it is accessed, what great response. We often hear of saves from those stations where somebody's had a cardiac arrest in the community. Public access defibrillator is accessed, applied, used, and we see somebody walk out of the hospital.
So Marty, you're the doctor in the crowd, although I've got some experience here. So I'm just going to start this out.
Well, I've had both.
For heart disease patients, or patients having a heart attack, going into a rhythm which doesn't sustain decent blood flow is a real life-threatening thing. But I think one of the reasons why we're talking about community programs for this is that if you wait to the time they get to the emergency department to put the defibrillator paddles on, it's far too late.
Definitely.
The gains can be made as early in the field as you can see these patients. You carry on there.
Well, and when people collapse, whether it's in an arena or parking lot or bowling alley, oftentimes the heart maintains an erratic rhythm, but just doesn't pump properly. And a quick application of an automated defibrillator, we refer to them as Fisher-Price defibrillators because they're literally so easy to use. There's basically 3 steps to them. And I would encourage anybody who has a partner or family member or even somebody in the community drop in front of them to look around where the nearest one is. They're readily available. Please use them. I've had personal experience with it. 2 of my friends, of course, at my age when you play hockey, you risk all kinds of injuries, but I've actually had 2 friends collapse on the ice. Both of them were in a heart condition called ventricular fibrillation, where the heart is basically just twitching. Both of them had automated external defibrillators applied, and it saved their lives. They're around and walking today with no deficits. We know that for every minute goes by, your chances of survival drop by about 15-20%. And so the faster you can get these defibrillators on, the more successful you are.
So should people look in the area they live and see where these are located? Is there a map out there that we can get? Or
the provincial government passed legislation recently to say that every public access defibrillator in the community needs to be registered. There is a registry for that, and there's a method for looking that up as that evolves. Within the county of Simcoe, like I say, they're in quite obvious and overt places, and generally where you would think you would find them. So again, in those community centers, I'm not sure if anybody hasn't seen one that's been out and about in the community at any point in time. Our program's been on for a very long time. We've looked to engage in a lot of agencies to get them in the community. We run maintenance programs with them. We run training programs to try and teach the public. We do mass CPR days, pre-pandemic, of course. We'll train 100 people at a time in CPR, because next to the defibrillator, right up against that, is the CPR skill that's been around for a very, very long time, but still very effective. So, as quickly as possible, defibrillation and then immediate CPR are the 2 most important things. A lot of people think you're going to have to do mouth-to-mouth with CPR or artificial respirations for folks. That's not necessarily true. There's actually no need for it in the immediate response. When the paramedics get there, or the allied agencies, they'll be able to assist with that. But for the general, the layperson response or the community response, the blood has a capacity to carry oxygen, unused oxygen, for quite some time in the body that we're constantly breathing in and out, but there's a level of oxygen still being carried. So the most important part is that defibrillation and that CPR.
It sounds like a lot of spin-offs that have been very helpful in addition to the defibrillator itself, so that's great.
It's interesting to look back as over the last 40, I can remember 40 years ago, dreaming of a day when every public fire extinguisher would have a defibrillator next to it. And we're approaching that now.
Good.
And so we're seeing them in shopping malls, we're seeing them in public centers like arenas and places where they're needed. So it's really come a long way in the last 40 years.
The science has really evolved. I remember, I've only been in paramedic service for about 25 years, and the first defibrillator I carried was huge. It was the size of your podium top, and it was quite heavy, and it had one job, and that was just to defibrillate. We're carrying monitors now that are half the size that can do a myriad of things that the paramedic can apply for cardiac pacing, for defibrillation, for monitoring, for 12 leads, 15 leads. That we're doing so many more things in the paramedic field. And those public defibrillators have become quite small and compact, not much bigger than a small, a basketball, and quite light and not dangerous by any means. They are a good tool. They're very well, marked and the instruction is very clear on how to use it. We see people, I mean, we give awards, 911 awards all the time. I've seen people as young as 6, 7 years old use these things and use them successfully.
Great. So JC and I went through a full list of topics that the EMS was responsible for and new ideas. We're not down that list at JS, so hopefully some of the other ones will come up in the question time. But at this point, I want to pass the mic over to Lisa, who's here to talk to us about mental health and OPP and how those two unlikely partners have come together. So share with us your experience and anything else that you want to about the OPP.
Yeah, thank you very much. In regards to emergency response, obviously the police are part of that equation along with paramedics and fire. And what we have found over several years is an increase in police responding to mental health calls. So for example, within the OPP, I can say that over the past 5 years, there's been about a 42% increase in those calls. They continue to climb. And as you mentioned, we've seen more of that through the pandemic. People are feeling more isolated and they're away from their families. Maybe they don't have regular access to their regular health care. So that's increased as well for a variety of reasons. And so over the past several years, the OPP has been working, as well as other police services, have been working towards integrating and partnering more often with mental health providers, just to address that component. We know that we're not the right ones to always be responding to mental health, but the reality is that often when we are scared for ourselves or for a loved one or someone we may see in the community, a natural response is to call emergency services. And so considering both of those, the OPP has worked for several years to partner with community partners in communities across Ontario. So I know here in your area, it's been the Wendat Community Services and just around the corner with CMHA at Simcoe County. And these partnerships enter the organization into an agreement where a crisis worker or a mental health professional from those organizations will work alongside police. So there's various models across the province. I'm a big proponent. I come from a rural community, so I'm a big proponent of there's no cookie cutter, right? So my job is to go out and meet with communities, and we were already talking about opportunities in the communities surrounding Midland, and we just sit down and talk about what you've got, what are the services you have and the partners you have, let's say in mental health, and what would you like to build, right, as far as responding together. So we try and establish something that's meaningful within the community and leverages the great partnerships existing to build something where the crisis worker will attend calls with police. Sometimes those are live ride-along police calls, so they're live calls that have come into 911 where it's been identified that there may be a component that a mental health crisis worker might be able to assist with. And so in some models, they'll travel in the cruiser or in the police vehicle with the officer to that call. And
so give us an example. I can remember something in my career a long time ago. I got a call to go and do a house call, and the wife said, "He's got a gun and he says he's going to shoot me." Mm-hmm. I was 25 years old. I had no idea what to do. But what would happen with that today?
So that one probably wouldn't qualify to take a crisis worker. And even if the crisis worker was with them, they probably would not be getting out of the car. So there is definitely there's a lot of risk management to partnering, right, in this regard, because whether it's with a community, we've talked, there's some communities who also engage their community paramedicine program, right? So whether you're going to a call for paramedics or police, or perhaps it's all, everybody's going, the gang's all there. If you're taking a crisis worker as well, there's an element of safety. They're going to be remaining in the car until the scene is deemed to be safe to engage them, at which point they're going to come out and have a chat with
Well, what was sad about the call that I went, and I did go to the house call, was the gentleman had a long history of mental health illness. Mm-hmm. He had a disease that was sporadic, and he had gone off his medication, And those were important things to know, but in my first response, I didn't hear any of that. So
No. And in the initial part of a call like that, of course, we wouldn't engage the mental health worker, but as the call progressed, if it were to de-escalate and any weapons were removed, and, there may be a role for a crisis worker at that point, right? If the individual was unwell and going to hospital, for example, prior to anything, any criminality being addressed, there would be perhaps a role for the crisis worker to do an assessment to assist the emergency department.
So of all the calls that the OPP gets, how many of them would involve some consultation or direct care from somebody with a social work background, mental health background?
I don't know if I can give you a percentage, Keith, and actually we're just in the process of looking to evaluate our combined programs because we, as I mentioned, we've got the mobile crisis response, and it's simple to look at our detachment to detachment, right? So from community to community, we can look at how many calls have involved the crisis worker in that detachment. Each of our detachments and their partners keep very comprehensive data around that. Collectively, this is fairly new work, so collectively we're working on how do we evaluate it on a broader level. So actually we've just rolled up a mobile crisis response team evaluation or review of the entire province, and so that will give us that baseline to then evaluate and collect on a larger scale rather than detachment or
So Marty, you must see these patients in Emerge. And now with a social worker rather than an OPP officer, right? From your perspective, what do you think?
So from our perception, patients will come to our attention always accompanied by the police. And that's because the laws in Ontario are that should it be brought to the attention of a police officer that a person may be at risk of harming themselves, harming someone else, or incompetent, then under the Mental Health Act, the police have the right and the power to apprehend them and bring them in for an assessment. Now, that sometimes happens in conjunction with paramedics. It sometimes happens just as police alone. There's two ways for patients to come to the attention of police. One is family members or friends will call. The other way is if you're having difficulty with, say, a loved one who refuses to take their medications and is definitely heading downward spiral, you can actually go to a justice of the peace and ask for a Form 2 to be filled out. And in that form, you're basically testifying that you feel this person needs to be seen and assessed. And so that gives, again, the police officers the right to apprehend that person, bring them into an emergency department to be assessed. Now, the difficulty there is that we're not really equipped in the emergency department to counsel and to deal with mental health. And that's a difficult thing for the mental health patients because they come to us at the tail end of having failed their community services. They haven't, their counselor, their psychiatrist. At the end of it, it's a Friday night. They're in a crisis. The police have apprehended them. They're upset. They come to our emergency department. And just to put it in perspective, our hospital sees about 130 to 180 patients a day. And if you divide that up, it works out to about 10 minutes per patient for the physician. If you have a mental health crisis, I definitely need more than 10 minutes to spend with you. And it's just not possible. And so one of the things that our patients struggle with is the fact that they come to us for help. We don't seem to offer help. But what we're actually there for is to assess them in terms of safety. And so our big job, number one, is to come to a decision about whether they need to be kept against their will for their own safety or whether they're safe to be discharged and treated as an outpatient. And that takes some time to just get to that, let alone providing counseling for something that's been, they've been struggling with for 20 years. Once we've made that decision, they're either discharged safely home with either medication or appointments to meet their counselor, or we fill out something called a Form 1, which allows us to basically hold the patient against their will. In the extreme cases, we may have to use medications to sedate them, to keep them in the hospital until such time as they can see a psychiatrist, usually within 72 hours. So they could be held in our emergency department. They may be admitted to the hospital and held there, but they're held for their own safety until they can get to the right counselor and start that process again, either medication or counseling. And so that part can be frustrating for families and for patients because the rooms in the emergency department are definitely not made for comfort, and they're certainly not made to reassure patients who have mental illness. They're basically made to keep people safe. And
Well, Lisa, this is a
those are
complex program. A lot of people involved, a lot of people saying, maybe the way we did it before was fine, and you're into change here. And I think the OPP has suffered sometimes because of bad publicity around mental health patients that haven't, in retrospect, might have been handled in a different way. What are the challenges that you've had in rolling this program out across the province? Because that's you're looking across the province.
Yeah, I think we were saying it earlier. The only thing that people don't like like less than they like change is for things to stay the same. So change can be hard for all of us, and just because we've been doing things in any of our sectors really for 40 some odd years doesn't mean it's the right thing. So I came to the OPP from healthcare, actually just 4.5 years ago, and I always joke that I've come to the dark side, and because I was in healthcare for a long time working with individuals who live with mental illness and would often advocate for them with the police. And I was supposed to only stay for a year, but I've stayed with the OPP because I'm really impressed and proud of the fact that they are making that change, right, and taking strides to engage in innovations in mental health, understanding that by default, their police everywhere across the world are going to get called for all kinds of crisis. And crisis isn't just about living with a mental illness or experiencing mental illness. We were joking earlier, I'm the mom of 5 kids. I feel like I'm having a crisis every single day, right? But anybody can have a crisis. It's really, our regular coping skills aren't working for us. So there's a need to have innovations, and the OPP has done that through their work in establishing mobile crisis response teams, and we continue to evolve that work. For example, linking them to community paramedic medicine programs, as well as really coming full circle and engaging in police hospital transition agreements that pull it all together, and collecting better data so that we can continue to improve. The other piece is the crisis call diversion program that I mentioned, and so that is taking the lessons learned over the past 5 to 10 years in the advancements in mobile crisis response in the field, and applying it by having those crisis workers or mental health specialists in our communication center, so that when someone calls in a crisis, they're offered the opportunity to speak to a crisis worker as a mental health specialist, and they get to choose, and they get to say, sure, that would be great, or no thanks, I really want the police to come. And it's interesting because just from a general public perspective, I think I would have assumed that everyone would say yes to the crisis worker, and when in fact 38% say no thanks, I'd like the police to come. So we're really learning a lot about how people engage in those emergency responses. And when I say not every crisis is a mental, it involves a long-term chronic mental illness. An example of our crisis call diversion program from like an actual real example is an individual who had called in a motor vehicle accident to report the accident, and they were offered, because that can be anybody in the audience who's had an accident. I almost hit a deer on the way here, so it can be a little bit alarming and cause you to feel like your coping mechanisms aren't working. And that individual was offered the service, the crisis call diversion worker, and they politely declined and said they would just wait for the officers to arrive. And then they called back in, and they asked if they could still speak to that crisis worker, and the call taker put them through to the crisis worker. And the individual explained that it wasn't an accidental motor vehicle accident, that they had attempted to die by suicide, and they ended up spending some quality time chatting with the crisis worker. And the great thing about that is the comfort level they had in calling back, that they had the option to call back and do that. And one of the key roles of that crisis worker, whether it's on our frontline mobile crisis response teams when they're going out with officers or at the call center, is that those crisis workers can offer referrals to local services, right? Maybe it's to WENDAT or to the CMHA, or they can link them to maybe addiction programs if that's something they're concerned about. And they have the ability to look at not only a regional kind of landscape of services, but provincial. So in our training, we really build that system navigation piece in a meaningful way, because that system navigation is so critical in longer term planning and avoidance.
The training is for who?
Sorry, we do training with our with the crisis workers. So in addition to their regular training, similar to what.
I guess do you do training with the police officers?
So we have a layered training program. So this has been up and running for a year. So we've got the four sites established, and what we've done each time, we've learned each time, right? And it's a new program, and it's the first of its scope in Canada. So what we've done is we've embedded several days of training for the crisis workers who, similar to the paramedics, come with their own education and experience in offering these specialty services. And then we do training with our communications operators as well. So every communication operator understands the program, how it works, how the technical component works of linking the crisis workers in. And then we do information sessions with our officers so that they understand the program as well, and what's in scope for that program and maybe what's out of scope for that program at this time.
So do you think it works better in small communities like ours where people know each other? The OPP officers know the crisis workers, and because these patients, it's not often, sometimes it's more than the first time, it's the second time, and so people know the situation and you don't have to go through learning all of that before. Or is that, or am I just assuming that it would be easier in a place like this?
I think there's two sides to that coin, actually. I don't know, what would you say?
I could probably comment on that.
Yeah.
The first thing I would comment on is the fact that in the last 10 years, I've seen a tremendous change in the skill set of the OPP officers bringing in patients with mental illness and their ability to de-escalate problems that, 10 years ago would have ended up in handcuffs and face down on the ground. So their skill set is just quite tremendous. Secondly, since COVID, we've had a huge uptake in mental illness and mental health, and we're averaging 3 Form 1s a day. For every Form 1 we see, Form 1 patient, we probably see 10 to 12 that the police will bring us, and so it's an incredibly busy part of their practice and ours. And so any help they can extend to us is we're very grateful for. But I can't comment enough on how well trained they are and how much the experience has changed for our mental health patients over the years.
Well, and I think one of the benefits for sure for the hospital is that there's this diversion piece of it, right? So for the mobile crisis response workers, because police officers are still police officers. They don't go to police college to learn to be mental health clinicians, right? They go to learn how to deliver public safety. And so having that crisis worker with them, where they may have previously just automatically taken the person to the hospital, to a small, busy emergency department with maybe that, and to your point earlier, Marty, that don't have the resources to deal with that person, they're diverting so many of those individuals from the hospital and keeping the individual who's already having a crisis away from that longer term frustrating process of waiting in an emergency department.
The other pattern I've seen develop across Ontario is that where there are centers of excellence, where there are psychiatric centers, the patients tend to group in that area, and so the skill set has to be higher. So for instance, a patient may be admitted to Waypoint, and if they're there for a few weeks to a month, the family may move to the area. So now when that person gets out, they settle in the area, they become known to our local police officer, become known to the local physicians, the local medical system. And so the numbers tend to be higher the closer you get to a center of excellence. So London, for instance, has a large mental health population. And it's really gratifying to see that the local staff and the local police officers, our hospital has recognized that, and in the last few years has put in place a crisis worker between the hours of 9 in the morning and 9 at night. And these are mental health professionals very well trained in dealing with crises, and they have access to computerized information that we don't with regards to our patients. And so there's a special computer system that deals with mental health issues. Our crisis workers often know the patients. They've built up a trust with them. They've built up a relationship. They usually know who the care providers are in the community and know how to reach them. And so that's been a huge help for us in the emergency department, because it's not something that we're particularly skilled at doing.
And the upside to all of our programs is that it keeps resources on the road and it creates system capacity in the medical system. So when you think of a community paramedicine program that's keeping people out of emerge, creates capacity for those acute emergencies that Marty and his teams are so well trained and really primarily there for, not necessarily for chronic illness management. When you think about the issues around mental health and the involvement of police agencies, you get a police officer on that call, he's attached to it. And he's out of the community, out of that public safety realm until that's dealt with. Mm-hmm. And if that means going to an emergency room that's maybe not as equipped as it could be, they could wait there for hours. It's not dissimilar to an ambulance, who 2 paramedics are bringing someone to hospital. We're stuck on a delay at times for hours because the system capacity is overwhelmed and there's just too much going on in that emerge. So every bit that we can do as emergency services, as responsible partners in the community to reduce the impact on the overall healthcare system, I think is one that needs to be endorsed at every level, whether it's municipal government, provincial government, federal government, all of our agencies. And we're starting to see that turn now where police and ourselves very specifically are looking at opportunities to intervene there. We're going on these calls anyways. Let's make a different effort. We're looking at opportunities to change. Our mandate has always historically been call, must go to ED, has to go to emergency room. It's the only place you can transport to. We're trying to make some evolution now. The legislation is starting to open up for us to make change that when we have a mentally ill individual, we can take them to the right facility rather than overwhelming that emerge. Or when it comes to other dependencies or the opioid crisis, we can go to detox centers, possibly. We're working on those avenues. We're working on those. There's a lot of challenges, a lot of risk mitigation to happen in between. But as you see programs like the ones that we're talking about today become more and more successful, those programs become much more easy to evolve because we're proven, we're evidence-based, we're doing the things that the community needs.
And you can look at that diversion rate. So I can think of one detachment off the top of my head that, I look at their data on a regular basis. They could see over 300 people in a month with that team, and they've got an 86% diversion rate. It's not unusual for them to have between an 86 and 90% diversion rate from the hospital. That's huge impact on a small community hospital.
It's so much better for the patient as well because you're going to the service that you need, not the nearest place where you can be sort of dumped off and watched.
And having, you asked about the relationship, Keith, and to go back to that, when you have a clinician going and an officer, I think it gives an opportunity to have a different conversation and to really build relationships. So yes, I come from a rural community and we've all met. The deputy chief is my cousin, so we've met. Keith has met one of my relatives, we found out. So we've met. And oftentimes, we can get compassion fatigue in our communities when we see the same individuals over and over. And I'm sure the individuals that we see from a policing perspective kind of get sick of seeing officers. So, I think any opportunity we can take to build new and different relationships is a benefit to everyone, the client, the person at the center of everything, who is the most important person, but also public safety.
Yeah, it's one of the huge.
This group just loves to talk. Lisa told me she didn't have any trouble. So, Marty, can I just hold that thought? Because I don't know. I'm not doing a very good job as a timekeeper, which is fun, actually. Yeah. The fire department is the other third arm of the 911 response, and Paul Ryan really wanted to send, Paul's the Midland Penetanguishene Fire Chief, and he really wanted to send some strong messages about fire safety. You can avoid fires and you can avoid the devastating burns. And in my career, I was at Sunnybrook and the burn center there, worked closely with them, and I can tell you, burn patients are one of the most compromised, difficult patients to treat, sometimes with good responses and many times not. And so when everybody sees a burn and you say, we could have prevented that, I think the messages from Paul should bring home. So he said there's 4 areas where we should strongly think about where burns start. So number 1, unattended stovetops. Leave something boiling, flip over, or take a sleeve and gets caught in the fire. space heaters, particularly around this time when it's cold. Make sure they're distanced from things in the room. Christmas lights, yeah, it's wonderful to see them, but if they're flickering and kind of little shocks here and then, those Christmas lights should go out. And the other thing was candle flames. Do we really need open candle flames anymore? So those were his 4 messages about if we could do something about those 4 areas, we could get rid of the fires altogether. Okay, now if the fire starts, if there's smoke, then of course he's going to be stressing the importance of your fire alarms and your smoke detectors in your house. And now with new technology, I mean, you can buy them easily. They yell, they scream at you, they flash, and they've got a good 10-year battery. So it's a much easier process. But get them installed and hooked up properly and learn them. Learn the tweets, what's a nuisance alarm versus what's a real alarm. And so those are the messages from Paul, and I thank him for sending them. He did say one thing, though, is if you have any doubts about the fire setup or what might cause fire in your home, just give the local fire department a call, and they'll either help you on the phone, or some areas they're willing to come out to your house and take a look. So follow up on that. So
Really great stuff from the fire department from that perspective. Their primary mandate is fire safety, right? The fallout of that is fires.
Yeah.
So the more work, much like we are all preventative in the work that we're trying to achieve, the fire department does an exceptionally good job at that as well with the prevention piece.
So the one thing I'd asked you to talk about, Marty, and I'm sure, well, you've had a chance to talk through the others, but to talk about the treatment and the diagnosis of stroke and heart patients. And I think we all used to think if I can just drive to the hospital and get there, that'll be the fastest way to go. And I'm hoping you'll make some comments on that.
Well, perhaps I'll start with strokes then. So there are some very clear warning signs of stroke. So if you have a loved one who's lost the function of an arm or leg or lost the ability to speak, the first place you'd be calling is 911, and you shouldn't delay. I've seen patients come in 4 or 5 hours after the fact thinking that it would just go away and it would suddenly get better. This doesn't happen. Or if it does, it happens so rarely that I've probably seen 3 cases in 40 years. But calling 911, the local paramedic service has the ability to redirect, not to go to the nearest hospital, but for strokes, for people showing clear symptoms of strokes. If we can reach you within 3.5 hours and provide you with a medication that breaks up clots, there's a good chance that you can have a full recovery. Our nearest stroke center is in Barrie. And so if you call here in Midland for an ambulance, 911, they will take you directly to Barrie. You'll see the neurologist. You'll get your CAT scan. If you qualify, you'll get this this clot-busting drug that's available. And so in the past, that was a very different treatment than what we would offer. In the past, you would come to the local hospital. We would try and nurse you through it and try and do some rehab and recovery. So there's this option now. The same with heart attacks. So patients who are having heart attacks, having chest pain, having difficulty breathing, shortness of breath, calling 911 is vital for 2 reasons. One is they will take you to the hospital, the nearest hospital, depending on your condition. Number 2 is the paramedics have ECG ability to diagnose a heart attack at the site. And if you are having a heart attack, once again, you're within 40 minutes to Barrie. They'll take you to the angiography center, the cardiac center, where they'll do a angiography and a stent within that first hour to hour and a half. And the faster that can be done, the more heart is saved. The more heart is saved, the better your recovery. So it's really, really important, I think, for people to be aware of that. If you have a loved one suffering chest pain of unknown cause, you need to pick up the phone, dial 911. Driving to the hospital, if they come to our hospital and present to our triage desk, the first thing we'll do is do an EKG. If we see signs of a heart attack, we'll call the local paramedics and they'll bring you to Barrie. And so if you want to short circuit that and save some time, pick up the phone, dial 911, get the paramedics to come and see you. They're excellent training. They're on the ball. These girls and guys know exactly what to do. And they'll take you to the center where you need to be seen. And so that's been a big change over the last few years, is the ability to go not to the near center, but go to the center where you need, where the care you need is provided. And so that's been a huge change.
Great. Thank you, Marty, for bringing that to us. And I'm sure when we get to the question period, we'll include you in some of those questions too, okay? So you've presented us with a a lot of really good ideas which are in progress and they're working. What are the areas that you have yet to make inroads on? You're kind of thinking, well, there's a problem, but I just don't have the resources, or I don't. So what are the areas that you're thinking in the next 3 or 4 years that you're going to be working on? Just give us a couple of examples so we know that.
Sure.
Jeez.
Okay, no problem. One of the bigger projects that we're working on is really expanding that community paramedicine program. We do want to maybe try to find our way into mental health support as well. Technology is evolving as much as our human resources are, and we've, you can see some reports that we've put out through committee and council. We've done some early legwork. We want to really leverage the community and the technology available to us to impact. Again, Marty speaks of early intervention. Early is best. And again, speaking to the rural space that we have at sometimes, we're looking at a couple of avenues of a community responder application. Everybody's carrying a smart device these days. We're connected way more than we've ever been. If we can find a way to capitalize on responders in the community that are willing and trained and capable, and putting a lot of structure around it, right? We don't want to be too freelance. Looking at opportunities for there to be a space where when the 911 call does come in, a notification if you're within a kilometer of an individual who could use a help from you, we may be able to notify community responders through that methodology and not just through the traditional 911 tri-services. And a further extension to that, knowing that cardiac arrest is most critically served by early intervention with an AED, with a defibrillator, we're trying to find technological advancements to be able to bring that to the community responder via drone. We're looking at opportunities to actually fly these things in the airspace to get them to people quicker, knowing that intervention can really save lives. If it works once, it's worth the effort. So we've done some trials, we've done some work with various agencies, so we're looking down the road at that. Like I say, there's a lot of reports that we've done over the past couple of years looking into it and showing some evidence. So that's our futuristic look as far as that goes. And obviously we're looking to expand our capacity to be able to transport to alternate destinations, treat and refer people to the agency they need to avoid the emergency room altogether, but also treat and release, do a little bit more work in the living room. We carry an emergency room at the end of the day between the multi-use monitor and defibrillator that we carry, all of the medical training that we have. There's a lot of stuff that we can avoid going to the emergency room for. Our community paramedicine program does that well. We have prescriptive power through our delegated medical authority. Marty's been here with us for a short period of time as the co-medical director of our community paramedicine program. The authority to work through Marty's license to do some of those prescriptive measures for short-term needs. We don't have to go to emergency to span and spay the gap of time and needing to get to that primary care physician or get that prescription renewed or initiated. So the future is really broad for us. It's something that we really want to capitalize on.
And Lisa, I know you're keen on this mental health project, but in your 4.5 years with the OPP, what other things are coming down the pipe?
I think that emergency services across Ontario are looking towards sort of a provincial call sharing, 911 next generation. So that will be something, perhaps of interest down the road for your program. As far as the mental health piece goes, I think that one of the things we're excited about is continuing to expand those partnerships. So, for example, we're just seeing a little bit of traction around linking those programs to community paramedicine programs, and then really building solid police hospital transition and paramedic transition teams almost or committees in each community, where all of, we still have this we have this sort of, we've always worked in silos. So we were all sort of a little bit still, we feel comfortable there. That's our comfort zone. And so just continuing to broaden that work so that we're collaborating and bringing all of this work together so that we can track and evaluate, are we doing a good job at diverting from the hospital and, freeing up those spaces at the hospital? Are we doing as much as we can, out in the community? And I think collaborating more intentionally is definitely the way forward for us as far as mental health goes.
So I was going to ask in the emergency department, I was going to make it broad, Marty, but somebody's already sent in a question here.
Yeah.
Let me read it to you.
We're hopeful that
I'm
most
gonna
of the
touch on some
projects
fingers here.
that
So-
help to divert upstream will take the pressure off us. But I have one project that I've been intermittent working on over the years, and I bring it out of the closet every now and then to see if the time is up. And I've lost my. So I've always believed that when someone is injured or there's an emergency, the sooner you get there, the better off you are. And so with that in mind, I've always had in mind the idea of having legislation, having our MPP Ontario, so that anybody who's a licensed driver also has to be licensed to. And so that way there, we would have it immediately. I mean, I don't know how many people drive in this province, millions of first responders. Were to happen on a downtown street corner, odds are there'll be somebody there with the training to help you until the professionals arrive. And so,
So a question that came in, Marty, and this is probably fairly operational, but I think it's important that most people who've been to an emerge see it. Ambulance workers often get stuck at the emergency room.
oh yeah,
How can hospitals change to get paramedics back out into the community faster?
I don't think there's any one answer to that, but I will tell you what an important part of that answer is a culture change. And I've worked at hospitals where there seems to be a pervasive belief among the staff that if we hold the paramedics here, they can't bring us any more work. And that literally is backwards thinking, because if they're tied up in the hospital, they can't be out helping your father, your mother, your brother, your sister. At our hospital, probably because 3 of our physicians have been paramedics in the past, there's always been an emphasis on when the paramedics are coming in the door, if we see them standing there, we'll ask the triage nurse or the head nurse, what type of a bed do you need? And we'll try and make arrangements. If there's a patient that's approaching discharge, we might focus on discharging that patient sooner to clear a bed. And so it has to be a team effort. It has to be the paramedics pre-warning. It has to be the triage nurse making us aware of what beds and what types are needed. It has to be the ability to move patients around in other than the standardized methods we've had. We've had patients come in who have stable illnesses. We'll do their blood work and have them sit in the hallway while we're waiting for their lab work to come back. That frees the bed up for that critical case coming in. That allows us to free up the paramedics. And our job in Midland has always been to get them out the door as fast as we can, because we want them available. We want them out in the community. They're an extension of the emergency department. The last place we want them is standing in the hallways. Now, having said that, I have worked nights where we've had 5, 6, 7 stretchers, paramedic stretchers. So there are times when the backlog is just tremendous, and no matter how fast you work and how hard you work here.
Well, thank you for tackling that. I know it's a tough.
Yeah, it has to be teamwork.
And once you find the right answer at your hospital, I'm sure there's 120 other hospitals out there looking for that answer, because it's a problem across Ontario. And as you pointed out, it's not good for patients, it's not good for the staff, it doesn't have an advantage. So
I was just going to add that the next portion of that is the downstream effect. So we have to free beds in the hospital to make room for the people that emerge to get admitted.
yeah.
And so I think the capacity is a situation that hasn't been addressed properly.
Okay, I want to take about a 1.5-minute break here. That doesn't mean people can get up and stretch. Well, you can get up and stretch if you like. But I want to recognize our sponsors, and I want to recognize, tell you a little bit about our next event. So I think there's a slide up somewhere on our sponsors. I want to recognize Georgian Bay General Hospital, Gail Hunt, a longtime supporter of our program, Waypoint Center for Mental Health, and Carol Lambie, who came on board this year as a sponsor, to the Center for Psychology and Emotional Regulation, and that's Anita Federici's group, to Audia Hearing Aid Center with offices throughout Simcoe County, and that's spearheaded by Andy Audia, to Hillcrest Village Care Center here in Midland, long-term care home, and run by the Enns family, to David Mink Insurance Services, now called McDougall Insurance, a big thank you to them, and to Lipton, Lois Lipton and her Lipton Group, who specialize in commercial property investments, real estate, and business brokerage. So to those 7 sponsors, thank you very much. Let's give them a big round of applause. I've been waiting to do that applause for 2 years. Okay. Our next program on February the 17th, 2022, that's 10 weeks from tonight. Christmas will be over, the New Year's will be over. So we're going to run a program called Our Hospitals, Our Health. Kindly, our 4 CEOs in this area, that's Carol Lambie from Waypoint, Gail Hunt from Georgian Bay General, Janice Scott from RVH, and Carmine Stumpo for the Royal Soldiers Memorial have all agreed to grace us with their presence. This will be an interesting discussion. When we started planning it, we didn't actually think we'd be quite where we are today, back into the challenges. Anyway, I look very much forward to moderating that event and to bringing those 4 CEOs together to talk to you, the audience. So at this point, I'm going to switch into some questions that we have either been sent or provided with. And so I'll try and direct it to our speakers if I think it's appropriate, or this group isn't terribly bashful, so if you just want to speak out, that's okay too. This is a neat one, who is ultimately responsible for making decisions? So I guess I should give you an example of which decision. So who decides at the 911 center what service you need, and what if there's a discrepancy? What if there's a gray area? How do you handle that?
Well, most people know what they need when they're calling, and the situation they're describing there's either a legal element, a fire element, or a medical element to it. When there's a discrepancy, is this a police matter or a medical matter? That's where we kind of diverge into those mental health calls. We'll send both. We'll send all 3. And there are certain situations that the criteria indicates all 3 must go. So motor vehicle collision, you're going to see all 3 agencies dispatched at the same time. However, the chest pain call in somebody's home, that's going to come straight to us. We're going to take care of that. And depending on the community, there may be assistance coming from a fire department and a medical first responder capacity. But anytime there's a gray area, always err on the side of caution. We're risk averse within the emergency system. We tend to avoid risk at all costs. And worst case scenario, we'll send everybody.
Okay, thank you. Somebody here has a question about what's the difference between 911 and 211. Lisa, do you want to handle that one?
Sure, yeah. So 911 will get you an emergency responder. So that's when you're going to call 911 and you'll hear, do you need police, fire, ambulance? And then it will be dispatched as was discussed earlier. 211 is, the person answering that will be perhaps a social worker or a system, what you would call a system navigator, who can provide you information about various community resources. So I might call from, I'm old enough to say, I almost said call from phone booth, but I would call using my cell phone. And, I might say, I am, I've left my home or my relationship. I have my 2 children in tow, and I don't know where I can stay. I'm in a town called Midland. I've made it this far on the fumes in my car, and I need a safe place to stay. I have 2 young children. I don't have diapers. I need some food. I need some diaper. So it's more of a social system navigation, and that the person on the other end of that can provide information about the various resources nearby. So it's a provincial. Actually, it may be national service that you can call and get that system navigation assistance. Okay,
so let's take it one step farther, and Marty, you may weigh in on this. Ontario was lucky enough to have a service called, I'll get it right here, the Telehealth. Telehealth. So again, a kind of quasi-emergency service, but when should we be calling telehealth rather than 911 or vice versa?
Telehealth's role is mostly to provide advice and to provide advice regarding care, and again, to provide advice regarding whether to go to the hospital or not. And so if you have a person in your family so for instance, a child with a fever, they seem to be okay, but they've got this fever. You may call the telehealth number and talk to the nurse on duty, and she will guide you through steps and as well as warning signs to watch for in the event that the child should get worse. and perhaps at what point you should be considering going to the hospital. And we've certainly had many patients come to us and say, oh, I had chest pain at home, I called Telehealth, and they told me to call the ambulance and come to the hospital. So their advice is solid. They're a phone call away. They'll provide you with evidence-based information. They'll give you advice with regards to common things. What do I do about an insect bite? What do I do about child with fever? What do I do with a high blood sugar? That kind of thing. But they're a great resource, and it's free. There's no charge. And again, they act on the behalf of the patient, so improve patient care, as well as diverting away from the emergency department where you may wait for 4 hours for the same answer.
Okay.
Yeah.
Okay, thanks. On a whole, do you see that there are more unnecessary calls that go to 911 that don't really need to go? Or are there patients who don't call 911, which, Marty, then you see at a later date? So what do you think? Tough question, but what do you think? Give us your gut on it.
I don't know that we'd put a balance, and I don't want to put any sort of indicator to somebody to second guess the call to 911. I think that the true answer to that question is there are a number of calls that may require that 911 response. Maybe it's not an emergency though. Maybe the system that we have currently today doesn't have the appropriate means in place to navigate that person through. So when you talk 211, we've partnered with 211 to help navigate. So we'll make referrals so that 911 call doesn't happen again in the future. We're looking for opportunities to transport in a different direction or to a different facility. So I would think, my gut feeling would be that there's probably more people that are waiting and walking into emerge and avoiding the 911 call than there are people that are calling unnecessarily. It does create a frustration point in a lot of cases when it does happen, but if you're unsure, my advice is always going to be to call. We're happy to come. We're happy to help you navigate the system if it's not necessarily a place where we need to transport, but we want to avoid the ones that aren't calling. Those true
Marty,
emergencies.
you see some of them that don't call 911 that end up in your emerge.
Certainly, yeah. And I see them, on the other hand, I've also seen patients call 911 thinking that they could beat the system because if you come in by ambulance, you'll get seen first. And I think that belief that is changing now because people are realizing that as an emergency department, when patients are triaged, they're triaged according to their illness and their stability, how stable their illness is. And whether you come in by ambulance or whether you walk in off the street, you're going to be triaged using the same rules. And so there are 5 categories of patients, starting from life-threatening to critical to walking wounded to, and depending on where you are, you may be asked to get off the paramedic stretcher and sit in the waiting room and wait your turn. And certainly people get angry when that happens, but again, we're dealing strictly with the fact. Do you have an injury that can wait? Do you have an injury that needs to be treated right away? Our job is to, I can give you an anecdote. I saw a patient not too long ago who I was suturing him, and he said to me, "Doc, I waited 3 hours tonight just for a couple of stitches." And I said to him, "But that's because we're busy looking after you." And he said, "Well, last time I was here, I was seen in less than 5 minutes." I said, "What were you here for?" And he said, "Well, I came in with chest pain." And I said to him, "Well, chest pain is a reason to have you come in right away and be seen right away. While I was busy seeing you with the chest pain, somebody else was waiting for stitches." And I think he finally got the concept down, but a lot of people don't. They think that because it's a tiny thing, it should be seen right away and out the door. Whereas those are actually the things that we're unfortunately have to wait because we're busy treating the strokes and the cardiac events and the really sick patients.
Okay, thank you. Here's another one here. Lisa, perhaps cyber activity. So this person wants to know, my system isn't working right. I feel as though people have information they shouldn't have. What's their direction? Where should they be going?
Well, I think that's more of an operational question. So I think that certainly folks can contact the police to ask if they believe there's a fraud that is occurring, like an actual fraud. That would be a good reason to call police. Okay. Absolutely. Okay,
because they are by default. It's not a fire and it's not a medical emergency, so by default it is to the police.
And it wouldn't, there's lots of what we haven't talked about tonight. There are different ways to contact services. So that might not be a 911 call because it's not an emergency, but I'm feeling a little concerned about this and I'm worried that something has occurred that's fraudulent. So you could call a police service, a police department, a police service, or a police detachment, and just ask to talk to the community officer and just say, I have some concerns about this, or I hang out with a group of parents that are concerned about this, and we'd like some information. And so there are other avenues to contact emergency services with maybe a lower acuity question.
Okay. We've talked about the use of 911 for medical emergencies, fire and smoke, and we've talked about accidents and police and worried about safety for people. Do you want to talk a little bit about other reasons why I should call 911? So I'm thinking here to an article I saw in the local paper a couple weeks ago of the local OPP communicator saying, if you see somebody that you think is weaving in the road and you think they're drunk, then give 911 a call. Is that, I actually didn't know that before. Are there other areas we should be using 911 for?
I can't really speak operationally, but I think just, the general rule would be, if you see something in the community that you think is a public safety issue, a serious public safety issue, then you should be contacting the police, right? So, something like your example could result in a serious collision, loss of life, and, if that's the case, then absolutely you should be contacting police to report that incident. And then they would take it from there and determine what type of response that would require.
Okay.
That's an important point. I think maybe not everything is 911, and that's where the hesitation is. People think the only access point to, safety services, whether it's police or not, is through 911. There's other mechanisms to get a hold of the police, and I think, I'm probably in the same boat. I don't have the local non-emergency number to the police agency in my phone. Maybe that is something that the public would definitely benefit from.
So Simcoe County, I think, puts out a sheet with all the local stations, and I didn't include it in the list, but from retrospect, I probably should have. So just go to Simcoe County, and you'll see on one of their websites that there's a very extensive website, Simcoe County. So.
And I can say your other police services, your municipal police services in your area are just wonderful as well. And they'll have, for example, a community officer, just like the OPP will, who could, talk to somebody about their concerns related to fraud, for example, or cyber safety, and give them additional resources and referrals.
And they all have those non-emergency lines for access, so you're not going to clutter the system unnecessarily.
Okay, a couple interesting ones here. Somebody's saying if you think that you're in a situation where you see somebody's threatening to take their own life, who should they call? Is that a 911 call?
Absolutely.
And is it police, or is it paramedic, or is it fire? Who will respond to that?
Well, I would say it would be a 911 call, and
Absolutely.
absolutely. And I think the other piece, if you're unsure, I think you have to remember and trust that the person who's going to answer the phone has some expertise that they're going to offer, right? So if often we're panicking and we might call and say, I don't know, I think I need, and I might rhyme off 2 of the 3, or, and the call taker may ask some additional questions to help gather more information and help with that decision-making process. And then you're going to get a call taker or a communications operator from one of the services that will ask additional questions to gather more information. And they're doing that all through the call process, through the dispatch. So you want to trust the people on the other end too, right?
The helicopters. You've got a helicopter landing in Midland. I think probably every local hospital has a helicopter landing. Who decides if a patient should go by helicopter or they should go by a land ambulance?
So the air ambulance system's another provincial entity. So there's 2 or 3 helicopters at any given time for the whole province. Their primary focus is high acuity emergency interfacility movements. So you get somebody moving from a smaller or a not so equipped hospital to a downtown trauma center or needing immediate, really quick care from surgeons. That's where that helicopter is gonna come in handy. The the decision point is in a few places. So if we're on scene at a call where we know it meets the stipulation for the field trauma triage guidelines, we can make the decision. A paramedic in the field will call for the air ambulance. They'll land on scene. We'll find the aid of the police or the fire service, find a good landing zone for that helicopter. We'll bring it right there, and we'll avoid, going to the local hospital. The physicians in the emergency rooms and in the hospital are very keen to make that decision as well. They'll make a call to Critical Ontario, triage the call, and see how quickly they can use the air ambulance resource. If it's not available, if it doesn't quite fit their criteria, it'll trickle to an emergency land ambulance. And again, depending on the criticality and what's going on in the community versus resource availability, we'll get there as quickly as we can.
I remember early in my career, they took me up in an ambulance or in a helicopter to treat a patient. And I thought, if anything happens to this patient, I'm moving around too much. I can't do anything. I have no technical skills. So after that, it made me really aware that the transport is only for stable patients.
Yeah. Well, and
that's something that's tough to get.
Yeah, we've done a lot of talking about our special programs, and I think the OPP would be in the same boat. Our frontline paramedics are they're our bread and butter, they're our mainstay. Those folks are working really hard in confined spaces, so that air ambulance cabin space is really tight and doing a lot of work in there. The back of an ambulance is a small space, and we're doing a lot of work back there. So our frontline paramedics that are in the community every day are equally as, if not more important than any one of our special programs. They wouldn't work if it wasn't for those paramedics. So understanding exactly what you're saying, that it is a tough environment, and we're not in a controlled environment. We're in ditches, we're on sides of roads, we're in people's bathrooms, and people find the most obscure place to be when they're sick in their home. Sometimes I think that they try hard to find the smallest space in the home to crawl into when they need an ambulance to come by.
I would love to carry on this conversation, and I hope the three of us do again, but it is, I do need to wrap this up. To our audience here in front of me and to our audience at home, it's been a pleasure to host this event. Thank you for attending. Thank you for watching us. We sincerely hope that you've enjoyed listening and watching and seeing our speakers, and that you've learned some new things to take home and that it's been helpful for you. To our speakers who make this program, thank you for coming through some rather difficult snow conditions and distance to be here with us for our first live event in 2 years at the MCC. JC, you know this system so well. Thank you for sharing it with us.
Thanks.
And Lisa, your passion, the experience, and you are definitely a well-educated change agent. So I think all of us are reassured that what's going on at the OPP under your direction will be well received and successful. If you can present like you did tonight to those people on the ground, and great. And Marty, as always, honest and forthright, incredible amount of experience in helping people. So thank you to the three of you and to all of you for being here tonight. So let us know. Let us know what you think of the program. You can reach us at mcc_ourhealth@outlook.com. That'll give you a chance to tell us. Thanks again to our 7 sponsors. We will see you again in 10 weeks. That's on February the 17th at 7:30 p.m. for a frank and informative discussion with our 4 CEOs at the local hospitals. And to all of you, a very happy holiday season. We're so thankful this year for COVID vaccinations, which are available to all of us who live in Ontario as a first or second shot starting at age 5. And for those of us...
This program is brought to you by Ignite TV. Now you're in command. Visit Rogers.com for more details.
Call the Rogers TV viewer response line, email us, or connect with us on social media. You're watching Rogers TV, Barrie.
What kind of show do you want to see on Rogers TV? What interests you? Log on to rogerstv.com, fill out a show proposal, and tell us about your segment idea. We want to know what you want to see. Rogers TV, only on Rogers.
mix it up as good as you used to.
Promised you'd be nice.